Ladies and gentlemen, you are welcome to this presentation of Masterclass in Psychiatric Medicine on grief. I'm Dr. Prosper Tettey Doe, registered psychiatrist in the United Kingdom. I'll be outlining the presentation, which will cover the following areas: the past psychiatric history, the normal grief, what it is, abnormal grief, and then the stages of grief, and briefly on management. The first one needs to look at is past psychiatric history of the person, whether there's any history of abnormal grief in the past, and also to distinguish the normal grief from abnormal grief, the following needs to be looked at. In normal grief, there is first preoccupation with the deceased, especially in bereavement. Secondly, there's pining or searching for the deceased. And thirdly, there's what we call somatic responses, which this includes crying, sleep changes, and appetite changes. And fourthly, there's mummification, where one leaves the belongings of the person who is deceased in the same position that it was before the person passed away. There are stages of loss, which I've put the acronym DAPDA, D-A-P-D-A. D for denial, A for anger, and B for bargain, and the other D for depression. And the final, which is A, is acceptance. So people may be at different stages of this grief process, and they may move from one stage to the other in the same day. But the final stage is when they get to the acceptance with the condition, and then they can move on. Now, abnormal grief also comes with various symptoms, which I'll highlight, and it's important. But before then, I just want to touch on some of the associations which also go with bereavement. Bereavement sometimes can be associated with hallucinations or illusions, and especially auditory hallucination, hearing voices, which is the usual presentation. Also, guilt is associated, and sometimes self-harm or suicidal thoughts. So all these need to be explored in bereavement. Now, abnormal grief, important, and also the functioning of the person is affected. Hallucinations may be associated, and more bizarre hallucinations, and which are varied. There's also protracted mummification, so it goes on and on over a long period. Self-harm is also associated, and even suicidal thoughts, which are prolonged in abnormal grief, and features of the deceased illness, what the person died of. The grieving person begins to show some of these features, and idealized view of the disease is also a feature. Now, in all this, one has to look at the treatments. Usually, psychological approach is the first line. But if it's severe, in that there's severe insomnia, and my mentor says sleep is food for the brain, so the one cannot sleep, and that means something needs to be done. That is where it's recommended giving what we call the Z drugs, like Zopiclone, etc., the benzodiazepines, for a very short period. And thank you very much for your attention. I wish you all the best in your career and in your studies.